Good evening. Welcome to this session topic, topic of group discussion topic on acute mesenteric ischemia. I think, or I might have read it wrong, but when I got the topic list, it seemed to say acute mesenteric ischemia, but in today's title, it's given as mesenteric ischemia, which, as you know, includes both acute and chronic. So I may not have slides on chronic ischemia, but as I was telling a little earlier, we can look at the main differences between acute and chronic ischemia at the end of the discussion. Okay, and as I keep saying, I would like people to actively participate in the discussion. And when you're not talking, keep yourself muted. All right. So when you look at, well, basically in the first 90% of your presentation only on acute mesenteric ischemia. When you look at what is said about acute mesenteric ischemia, please note this quote is 100 years old. Okay. And he says occlusion of the mesenteric vessels is apt to be regarded as one of those conditions which the diagnosis is impossible, the prognosis is hopeless, and the treatment is almost useless. Okay, 100 years on, I think the only thing that has changed is the first part of the statement. Diagnosis is possible, but even now, prognosis is hopeless, and the treatment almost always. There are some exceptions, and we'll learn about what those exceptions are as we go along. The treatment is almost useless. All right. I can tell you in the 40 years of, from 86 to now, 82 itself, you can take it. 40 years of my treatment, I have not salvaged more than 3 patients with ischemia. And all of them were younger patients with embolic ischemia, not the older patient with the atherosclerotic ischemia. Okay, so that is the disease. And so we'll start by understanding what AMI is, acute mesenteric ischemia. All right. Tell me, what did the book say about it, Samir? Is Samir there? Samir is not there.
Yes,
Maybe.
sir.
Go on, Samir. What do you understand by this term?
Sir, it is defined as a sudden interruption of blood supply to a segment of small intestine, which leads to ischemia, cellular damage, then further necrosis, and eventually
May
death.
lead to necrosis.
Yes.
Correct. That is the correct thing. Okay. Potentially fatal, sudden interruption of the blood supply of the bowel. Okay. The consequences are variable. It may go from relatively minor ischemia to some cell death on the mucosal aspect to transmural necrosis, later on leading to perforation, peritonitis, and that's why it's potentially fatal. That's correct. A sudden interruption of blood supply to the bowel. So what are the basic mechanisms by which this interruption can occur? Supreet.
Good evening, sir.
Good evening.
Sir, in textbook, it's occlusive.
Just tell me textbook or thin air or journal, doesn't matter. Has it gone into your thinking and your memory is my question. So
sir,
tell me, what are the mechanisms?
So it's broadly divided into occlusive and non-occlusive mechanisms.
Very good. Yes.
In occlusive, arterial blockade or venous blockade will be there.
Very good. Yes. Anything more to say? The arterial blockade, are there any types that you can think of?
Arterial embolic.
Yes.
And atherosclerotic.
Very good. That's all you need to know. Okay. It could be arterial, venous, or non-occlusive, as you said. Okay. The arterial, it may be embolic, thrombotic, or it could be a dissection. Okay. What is a dissection? I put it in small letters. Can you think why?
Less.
Very rare. Yeah, incidence is very rare. But what is a dissection?
Separation of intimal layers.
Correct. So usually at the beginning of the major artery SMA from the aorta, you can have a flap of the intima blocking the surface. It can happen further distally also, but most often because the eddy currents is at that junction where the SMA takes off from the aorta, most often it happens at that level. So these are the basic mechanisms by which acute ischemia may occur. So when you think of a workup or a clinical condition, clinical assessment and things like that, what you have in mind is always a differential diagnosis. What can it be? And so apart from the condition that we are looking at, which is acute ischemia, you must look at all other possibilities that may happen and then rule them out before you come to a diagnosis of acute mesenteric ischemia. So to that end, you must have a list of common diseases that may be that you may have to consider when you get a patient with AMI. Praveen, can you give me a DD?
Sir, bowel obstruction, sir.
Yes.
Intestinal perforation.
Yes.
Acute colitis.
Yes.
Ruptured abdominal aortic aneurysms.
Okay. Correct. Yeah, this is how I keep saying you end up with a shortage of conditions. So I keep on telling you, in your mind, you organize your data. You can consider it as vascular and non-vascular. Okay, the first three things you mentioned were non-vascular. All right. So inflammatory conditions, pancreatitis, cholecystitis, perforation, intestinal obstruction, and the like. So what are the vascular things you can think of, but not which don't come under the heading of acute mesenteric ischemia? In mesenteric ischemia, you must have one of the larger vessels involved. Okay, one of the larger mesenteric vessels involved. So I'm giving you a big hint. Where do you think the smaller vessels, including arterioles, can be involved? Nikita?
So, in a malignancy situation, sir?
No. It's not vascular, is it? I'm talking about vascular conditions. See, this is something if you read the books, you will know. So I just want to know whether you read the books or not. As a differential diagnosis, they'll always mention it. I've also given you a hint. These are the smaller vessels involved. What disease affects the arterioles, for example, or the finer branches in the wall of the... Sorry?
So vasculitis.
Yes, Sainas, good. Something similar to that. You're right. Okay, you can have a fibromuscular dysplasia. You can have external blockage, median arcuate ligament. You can have vasculitis. You can have collagen disease. And you can have necrotizing segmental enteritis. You've heard of this condition? Segmental enteritis? Kritika, what do you think a segmental enteritis is?
So only few of the vessels are involved.
What is the mechanism? I'll give you a very big hint. Patient presents to you with diarrhea and vomiting of 4 days duration, with some pain and some dehydration. And on the 5th day, presents to you with intractable, terrible pain, which is not settling down, even with narcotics. This patient is likely to have a segmental necrotizing enteritis. What is the mechanism? Anybody? Sanya?
Sir, occlusion, like there is a vasospasm.
No, it's
because of-
not spasm. It's not spasm.
So secondary to infective, like Clostridium.
No, it's not even just vein infection. It is an immune reaction to the infection. Okay, it could well be, any enteric organism which causes infection. There is an immune reaction to this, and that forms antigen-antibody complexes which are solid, which means microscopically solid, and they can block the arterioles and give you segmental ischemia going on to even necrosis, for example. That can happen. All right, so that is necrotizing segmental enteritis. So these are the differential diagnoses. Please note that AMI, acute mesenteric ischemia itself is rare, and these are even rarer. But as doctors, you must be aware of this, because when you take action, particularly you have very little time, very little reaction time when you're faced with somebody elderly with a bad abdominal pain, not settling down with narcotics and looks ill. You have to take quick action. And so you have to have these things in mind. Okay, it's a simple enough thing, and I'll let you know as we go along how you differentiate between these. Okay, so as I kept saying, the incidence of AMI is really very low, 0.1 to 0.2%. So even fossils like us will not have seen too many of these conditions. We have mentioned arterial, venous, NOMI and everything, but large majority are actually arterial occlusions. The others form a very small 5 to 10% of that group. So what do you think the symptoms would be, Nikita?
So it's usually acute abdomen pain. Abdomen will be there, sir.
Yes.
History wise, and there could be nausea or vomitings also.
Yes.
And abdominal distension could be there, sir. Patient could be toxic, like tachycardia and hypertension.
Right. Very
if
good.
it is presenting delayed.
Right.
Yes, sir.
What is the sine qua non, the pathognomonic feature of mesenteric ischemia? Every article says that. That's the
Pain
only
is
thing you
out
must
of
remember.
Proportion.
Out of proportion.
Pain is different.
Correct. Pain out of proportion to signs. Okay, remember that. This patient comes to you with abdominal pain. There's nothing specific which tells you that this is AMI. Okay, people with known heart disease, people in the ICU, or elderly in the outpatients without known heart disease, when they come with acute abdomen, particularly severe pain, tachycardic, tachypneic, the pain itself gives them these signs. Always entertain the possibility of an acute mesenteric ischemia. You'll find that they'll be writhing in pain, cannot be comforted even with morphine, and you touch their tummy, it's actually quite soft. There is no guarding or rigidity. But and they can also present with GI bleeding. They can present first as sepsis, as you said, in shock. Okay, hypotension and organ failure can also occur. If you have distension, guarding and rigidity suggestive of peritonism, you've lost the game. If it is AMI, okay, that shows bowel necrosis, and it is very, very difficult to salvage them. It is known that every 6-hour delay from the onset of the occlusion increases mortality by 20%. Okay, so the patient has to come to you quickly. You have to diagnose it quickly to help about 10 to 20% of these patients. 80 to 90%, you really cannot help. So there is nothing very specific. Even this pain out of proportion to signs is not very definite. It can always be confused. So the only way to understand or diagnose the disease is to have a high index of suspicion. And the only way to diagnose it properly is to have a CECT quickly. Okay, you may think it's an overkill, but it doesn't matter. We will look at all the tests that you can do. You will also learn that none of them is really specific. None of them is pathognomonic into any, even the slightest extent. So what you have to do is have a low threshold for suspicion of AMI and carrying out CECT, contrast enhanced CT. This CT should be only IV. It should not be given oral. Can any of you tell me why?
Sir, already there is ischemia.
Mhm.
So if we give this thing, basically the demand will be more. So it will further aggravate pain.
Too complicated. There's a much simpler explanation, Nitya. Demand won't be more. Obviously, you don't use barium. You have to use a water.
So it can obscure the mesenteric vessels and
Excellent. That's the reason. So if you need to be able to visualize the junction between the aorta and the SMA. For that, you have to have not only an AP view, but also a lateral view. That's called the biplanar CT. That's a requirement for vascularity. CT angiogram. You need a CT angiogram, not just an abdominal CT. And so if you have bowel, contrast-filled bowel sitting in that area, which it can, then you may not be able to visualize the junction of the aorta and the SMA. So it's a simple explanation, only IV contrast and biplanar CT, and get not only just a CT angiogram, the conventional CT of the abdomen, but also a CT angiogram. That's what's important. So what are the signs
Sorry
would
to
you
interrupt, sir.
go on?
Ramakrishna sir has joined, sir.
Oh, thank you. Thank you. Ramakrishna, welcome.
Oh, good evening, sir.
Please interject, and if you have to add something, please feel free. Okay,
Yeah,
thank you, Nitya.
I'm listening, sir.
Yeah. So, what signs would you expect from a patient with AMI? Go on, Supreet.
He might be hypotension, sir.
Okay,
Hypotension.
okay.
Uh,
See, if you want to list the whole thing, I keep on saying, think of all the possibilities that may occur in an orderly manner. So you may have systemic symptoms, you may have local symptoms. So what would be the systemic symptoms?
Systemic symptoms.
Sorry, signs. I'm sorry, we finished this. Signs, I should be specific.
Systemic symptoms will be, by patient will be having tachycardia. So tachycardia, hypotension. And on local examination, diffuse tenderness over the abdomen, we can.
Correct. Okay, and as I mentioned there, if you have guarding and rigidity and perhaps a degree of distension, it means patient needs surgery. Okay, what surgery it is, something we can discuss later, but it essentially means an advanced stage. So you really have to catch these patients through CT with minimal signs in the abdomen before they develop peritonism. Peritonism is features of peritonitis. All right, that is the aim. As I said, that will perhaps happen in about 10 to 20% of cases. Large majority, you will not be able to get them this early. So if you look at laboratory and radiology diagnosis, what are the things that we would consider? Ainas.
So the routine investigations,
right?
That will include.
What would you mean by that? And what would you expect in that?
So CBC, in that we can see maybe an elevated total leukocyte count.
Elevated, yeah. What would be the kind of elevation there? Is it something specific about AMI compared to, say, a perforated bowel?
So the immature WBC's elevation.
Anybody else? Nitya?
Sir, more of neutrophilic leukocytosis.
Yeah, please note, it's a very simple thing. If there is ischemia of the bowel, it's true for volvulus with ischemia, it's true for AMI. Your white cell count will be very high. No doubt it will be, neutrophil predominant, shift to the left, all that, but that's not the main thing. The main thing is your white cell count will be 25, 30,000. Okay, even 40 maybe. So please remember, it will be very high, whereas these will be 15, 16, 18, like that. Okay, the other kind of infective things. In ischemia, the white cell count is very high. Let me first make a statement that all the lists that we talk about AMI are not pathognomonic, not reliable, but they're all corroborative features, and it is something for us to know. So if somebody has an acute abdomen with a white cell count of 13,000, it is unlikely that it will be ischemic. If it's 25, 30,000, very likely it's ischemic. What else?
Lactate levels, sir.
Lactate, correct. What else? You're right.
ABG, you will have metabolic acidosis.
Correct. Anything else? All right. Very high at WCC. CRP will be very high. D-dimer will be high as well. Okay, because there's a lot of clotting involved. So D-dimer will be high. But again, look at the first line in this slide. Variable and unreliable. So if you're looking at radiology, what are the tests you would do? And I already told you the answer is already known. The minimum correct thing that you need is a CECT. But it's not, you may want to do something else. If so, what would you do and why would you do it?
Angiography, sir. CT angiography.
That is mentioned. No, that is the specific thing. CT abdomen, CT angiography, I mentioned in one breath. But other than that, would you do something else? If so, why would you do it? All right, go on. Kritika, tell me.
Sir, I think CT will probably give
No, other than CT, Elama. If so, why would you do it is another question. I agree.
And-
CT is
Direct
the
X-ray, sir.
okay. Well, quite
and
right. Why
and
would you do that? What will it tell you?
First to rule out perforation.
Okay, free air, and what else will it show you? Possible obstruction.
Yes.
Okay.
Yes.
Yeah, I agree. You do not waste time if the suspicion is very high doing all this, but you must know what are the other possibilities and what can be done. Okay. And so in radiology, you want to do a plain film, free air in perforation, all right, maybe interstitial obstruction, ultrasound to rule out other diseases. It could be, we told you, one of the differential diagnoses you mentioned, non-vascular, was as simple as cholecystitis, appendicitis. All right, you mentioned aortic aneurysm. I agree. So you can do that. But as I said, CT with angio, CT angio is the procedure of choice. And I've told you why you do not use oral contrast. It has to be only IV contrast. I'm just going to show you some pictures of this. I've borrowed it from the books because actually I haven't had any cases which I have salvaged other than the 3 that I mentioned about. And in that, I didn't have the benefit. I don't have those CTs with me. So my pictures, the clinical pictures are all my own, but the others are all from the net. You can see how this is the SMA and there is no opacification. It's blocked by a clot. Okay, and this is the aorta, and that is white because of the IV contrast. Beautiful picture here. This is the aorta, and you can see the SMA taking off. SMA, celiac axis, and inferior mesenteric arteries are the anterior branches of aorta, as we all know. And you can see the filling defect here. Okay, and so that is the kind of delineation that you can get. Here, there is a long segment embolus in the SMA, and you can see the bubble. There is no opacification of the wall. You know, if the vessels were patent, you would expect this to light up in the wall because there is no circulation there. It's distended. You can see the kind of thickening of the bowel wall, which is due to the edema of the wall, plus non-opacification or not lighting up of the wall. That's what they call hypo-enhancement. Okay, so that is the kind of picture that you see. And this happens very early. And so, as I said, as soon as the patient comes, if you suspect it, you can get it done in an hour or two. In an hour or two, you'll find this kind of a picture. Okay, and would you do any other workup? I'm giving you a big
Cardiac
hint.
workup, sir.
Correct. So quite right. That is the line in which you have to go. It could be something that is, inciting this. So what other workup would you do? Cardiac is one. What would you do in a cardiac workup?
So 2D echo.
Okay.
And also, basically, we have to rule out atrial fibrillation because it can
Correct.
shove an emboli.
Correct. And look at in the echo, what do you look at?
Presence of any clot in the left.
Clot in the atrium or the ventricle or on the valves. Vegetations on the valves. Would you do an ECG?
Yes, sir, to rule
Why
out
would you do that?
arrhythmias.
Arrhythmia is one. What else is important? I told you that you could probably look for a clot in the ventricle. Why would somebody get a clot in the ventricle? MI. All right. So, excuse me, you do an ECG, you do an echo. Okay, what else would you do? Cardiac workup is one. What else? Think of the other causes. If somebody has a venous obstruction, what are the things that you should know about venous obstruction?
DVT.
Sorry? DVT. Yeah, okay.
Coagulation profile, sir.
Yes, coagulation profile. In particular, what would you do? What would you look for?
Protein.
Something that makes them prone to
Hypercoagulable.
hypercoagulability. Yes, good. And what would we look for in NOMI?
Vasospasm, sir.
Yeah, spasm you can't establish, but you look for the inotrope and the underlying cause of sepsis, which in the first instance gave you the need for an inotrope use. Almost certainly it's because of persistent sepsis and hypotension, where you use high doses of inotropes that gives you non-occlusive mesenteric ischemia. Okay, so you look at the ECG and the echo in cardiac workup. For sepsis, you look at the blood, urine, and sputum culture. Just for sepsis, because sepsis leading to, as I mentioned, the need for inotropes can cause NOMI, and you want to make sure that you address the underlying cause, diagnose sepsis itself with procalcitonin, and as Nitya mentioned, blood gases and metabolic acidosis. And you also have to use PHT workup for venous disease. Okay, so we look at venous disease in little more detail, but at this stage, you need to look at PHT workup, portal hypertension workup with a portal venous Doppler study and an ultrasound. These are the things that you have to do after you have diagnosed mesenteric occlusion with SECT. At this stage, can I invite comments from Ramakrishna?
Nothing, sir. Can acute pancreatitis produce this or mimic this, because the symptoms out of proportion to?
Yeah, in two ways, sir. Acute pancreatitis itself can, because it is so deeply situated, the pain may not give you too many abdominal signs. That's number one. But the actual inflammatory process can induce venous thrombosis. You can get portal venous thrombosis with pancreatitis, and that can give you venous ischemia of the bowel. So pancreatitis is very much on the list when we have a DDs.
Yes.
Ravi, your comments?
Yeah, I wanted to mention pancreatitis. I think that Dr. Ramakrishna has mentioned. Yeah, that's the...
Okay, any questions or doubts from our registrars and students? Okay, let me go on with it then. Yeah. So what has happened is that there are, just like your cardiac units, and if you look at the literature, like the cardiac units and the stroke units for the brain, we now have intestinal stroke units. They actually call it intestinal stroke. Ravi might have seen one in Manchester. Did you, Ravi?
Yes, sir. We used to get a lot, but unfortunately, we used to get those patients already having suffered from these things.
Yeah.
You just try to salvage them rather than.
Yeah. So what has happened is, even though they have not been very successful, some of the Italian groups, this is an Italian group which published a paper in British Journal of Radiology. It's an Italian group. They have tried to see if they can classify these radiologically. They do a CECT and then they know where the blockage is. So this S1 is proximal. Almost certainly it's a stenotic thrombotic episode. If it's embolic, it can be anywhere. So just by looking, they have divided the SMA into 3 parts up to the inferior pancreatic origin of the inferior pancreatic duodenal artery. From the origin in aorta, it's S1. From that point down to the middle SMA, the ileocholic artery, it's the middle SMA. And beyond the ileocholic artery, they call it the S3 or distal SMA. And they have tried to classify all the SMA thrombosis or embolism into where it fit in. And then they've tried to do a subgroup analysis to see if the prognosis or the approach would be different in any of these 3 things. And it really hasn't worked out very well. But I mentioned it because this is the only what shall I say, advance that I look when I was preparing for this talk. This is the only advance that I came across. Rest of it is about the same, which has been going on for decades. So this is something, and with this kind of classification, if more and more people attack it aggressively, attack the condition aggressively, we may have some success. But as of now, I can tell you that it hasn't made a huge difference to the outcome. We must understand that the large majority, I'm now talking about arterial disease, not venous, not NOMI. Please understand that. The large majority of arterial disease obstruction is stenosis with thrombosis. Some of it is embolic, but this data is questioned in some other papers. So I don't know which one to believe, but the large majority would be thrombosis with an underlying stenosis to start with, atherosclerotic disease. And as I said, dissection is an extremely small area. It is important to know this because embolic treatment, the treatment of embolic disease, may well be through endovascular. If you see it early enough, may well be through endovascular intervention. Whereas if it is stenosis and thrombosis, then endovascular intervention can be tried, but not very successful. It's been known that open surgery is still the gold standard, and I will talk a little more about it as we go along. Okay, so that is about arterial. When we talk about SMV thrombosis, we just mentioned a few now. What are the things that you can think of that can cause SMV thrombosis? Samir, you want to have a go? I mentioned 2 or 3. So you can think of, I already mentioned one, congenital hypercoagulable states. Okay. So get a broad category and then we can have examples in each. Ines, go on.
Malignancies can
all right. And
any previous like abdominal surgery.
Correct. Very good. Abdominal surgery itself is a hypercoagulable state. Remember that. Okay. That's why the concept of prophylactic DVT prophylaxis has come into being. Yeah. Just the fact that you've done surgery, not just abdominal, even orthopedic operations, gynae operations, they're all important. Yeah, you're right. Good. Anything else? So as I keep saying, please classify them. Okay. Then you will have the ease with which you can understand, and then recount when you're writing an exam, or even when you do when you entertain your differential diagnosis and undertake tests. Thrombophilia is a tendency to clot easily. It could be congenital or acquired. Congenital is protein S deficiency, protein C deficiency, antithromboplastin factor. And there are, some 23 conditions there. I don't remember all of them. Neither do you, but you can ask for a battery of tests which will tell you if there is any particular factor that is responsible. Acquired is things like post-operative state, malignancy, and general malignancy. I'm not talking about local malignancy next to the pancreas. That is also important, but malignancy anywhere, even a prostate cancer, for example, uterine cancer, makes them more prone to thrombosis. Chronic venous insufficiency, almost due to portal hypertension. And so you have to do a workup for portal hypertension. It could be, again, as you know, post-hepatic, pre-hepatic, or hepatic. All those causes have to be entertained. And the local causes in the pancreas and the retroperitoneum will involve inflammation. Pancreatitis is a classic example, and tumor in that area. It could be any adrenal tumor, pancreatic tumor, or a large gastric tumor invading posteriorly. It could be any tumor, or even secondaries in the lymph nodes, or a huge lymphoma, for example, retroperitoneal. All these are local causes which makes them prone to venous thrombosis. But note that only half of the cases with venous thrombosis have actually bowel ischemia. A lot of them do not have ischemia because it's a slow process. It's not an acute, sudden thing that happens. Even though we consider it under acute mesenteric ischemia, in some cases you can have extensive thrombosis when it can become an acute thing, but it is less common than the more chronic, insidious thing. So when there is an insidious clotting, it also opens up in due course. The clots get lysed by the internal mechanisms, and you get, for example, what's called a cavernomatous transformation of the portal vein. That's what you see in many chronic cirrhotic cases. So getting an acute ischemic episode is not common, but can occur. That's something you have to bear in mind. And of course, the NOMI, non-occlusive mesenteric ischemia, is a low flow state. Most often sepsis, it can be severe dehydration. Patients are on 2 or 3 inotropes. The SMA will be patent, and you can see segmental spasm or narrowing on your CT. The interesting thing about that is that this spasm does not occur at bifurcations. So, but if you have a clot sitting in the bifurcation, it's blocked. You don't see it opacified. But in NOMI, you can see that the bifurcations are spared. That is the important thing about NOMI. Okay. So we next go on to understanding. As I told you, prognosis is hopeless when there is transmural necrosis. Okay, I have repeatedly said that most cases that we see, you will have transmural necrosis, but how do we recognize it? How do you have to prognosticate before you intervene and tell the patient what you expect. So what do you think are indicators which tell you that there is possible necrosis of bowel? I've mentioned quite a few of those already. You just have to try and organize your thoughts. Kritika.
So an elevated neutrophil count.
Start with symptoms, signs, and then lab. Yeah. Always have that order so that you can recount correctly. Yeah.
So if the patient has any severe pain abdomen or passing of any
pain abdomen can occur even in ischemia without necrosis.
Passing blackish stool.
Okay. Bleeding rectum. Okay. That means mucosal necrosis. Yeah. But that doesn't tell you transmural necrosis.
Fever.
Okay.
And in signs, if there's presence of sepsis, tachycardia,
yes,
tachypnea,
yeah,
low PO2,
yeah,
lactate, metabolic acidosis, high neutrophil.
Yeah. Okay, these are the things I mentioned earlier. Signs of peritonitis, okay, in the abdomen. Signs of organ failure. There may be a renal shutdown, as you rightly said, low PO2. Patient may be going to early ARDS. You mentioned lactate, which is correct, distension. And in radiology, gas in the wall of the bowel, which is pneumatosis. Not very common. We all mentioned, in the exams, we jump at the students if they don't talk about pneumatosis intestinalis, okay, in ischemia. But the actual fact is that it's seen only in 5% of cases. So this is what I keep saying when we teach and when we examine, we should actually give them the actual data. Portovenous gas in the portal vein, for example. These are things which tell you that the case is probably beyond salvage. That doesn't mean that you don't do anything, but you can explain the poor prognosis to the patient. And compared to all other strokes, intestinal strokes have a very poor prognosis. We have, excuse me, we have learned enough to salvage CVA with thrombolysis. We have learned enough to salvage MI with emergency stenting and things like that. But in the intestinal ischemic group, easily the mortality is around 70%, and 10 to 20%, you may have some luck and you may salvage them. Even if you salvage them, please understand that it's a very, very prolonged recovery with a lot of support that is required. I'll tell you about what those things are, and a lot of expense, which many of us in this country actually cannot afford. But so the question is, how aggressive are you with these people? And if you find that they are not of a socioeconomic group where they can afford very expensive treatment, it's not that the hospital charges, just the medication is very expensive. The support that you have to give is expensive. If that happens, you should really think whether you should salvage them or not. Okay. So once you have diagnosed it with CECT and you know that you're going to do something about it, what are the things that you do? What would be the medical course of management? Samir.
Sir, first fluid resuscitation should be made.
Very good.
And whatever electrolytes.
Yes, fluid and electrolytes have to be maintained, correct?
Broad spectrum antibiotics should be started.
Right. Very good.
And as you said, sir, if there is any signs of peritonitis, you should go for lab protein.
Correct. You're actually right. Okay. So hydration monitoring is very important. So you've got to put an arterial line, a central line, get blood gases, get electrolytes, give the whole thing. This may sound as a very counterintuitive thing, particularly in NOMI, you don't want to use inotropes. But many of them, as I told you, 70-80% are all because arterial. So you need to have some degree of pressure in the arterial system before you can, get the perfusion to the bowel going. So that is, you do need to use inotropes. Okay. If the patient is already on maximal inotropes, then it's an issue. So there are certain broad indications, not everybody is agreed on it, as to which inotrope is the best to restore splanchnic circulation. Any guesses on that? Sanya? What are the common inotropes that we use?
Noradrenaline.
Okay.
Vasopressin.
Yes.
What's up?
That's all.
Dopamine.
Dobutamine.
Dobutamine. Among, you're right, these are the three common ones. Among these, which one would be the best for splanchnic circulation?
Noradrenaline.
No, dobutamine. All right. Norad and isoprolene are very bad for mesenteric circulation. Okay. And so splanchnic circulation. So the no universal agreement on this, but it's probably better to use dobutamine. Anticoagulants, very useful both in arterial and venous, and it can be the only treatment in venous coagulation, in venous MI, mesenteric ischemia. Okay, anticoagulants are important. And in NOMI, there is some evidence that prostaglandin E1 infusion reduces mortality. That is only for NOMI, not for arterial, not for venous. Okay, these are the broad headings under which you would do medical management. So if you are intervening, tell me what are the basic interventions that are available. Okay, who will tell me? Nitya, go on.
Endovascular,
Okay.
basically embolectomy. If there is an embolus, then we
Okay.
can
Again,
do an
endovascular and surgical. In surgical, what are the types you can use?
surgical. If
Open
there
and
is,
laparoscopic, no? It's very simple.
yes, sir.
Have the headings, yeah. So in endovascular, what are the things that you can do?
One is embolectomy.
Okay.
Then thrombectomy can be done,
Okay.
and we can put a stent, like
Okay. Agreed. Well, what else?
in surgery.
Mhm.
This thing, endarterectomy. If there is
Mhm.
any
Correct.
thrombus there, then endarterectomy.
Okay.
And if there is a segment of bowel which is gangrenous, then resection.
Correct. Only endarterectomy, anything else you can do in surgery?
Bypass, sir.
Yeah, bypass. So in endovascular procedures, you can do a thrombolysis, selective catheterization, and put some papain or something to lyse the thrombus there. You can do an aspiration embolectomy. You remember, you've gone in early, and so you have you can put the same catheter and suck it out, and so the embolus that is sitting there may, with a bit of luck, come out. You can actually do an angioplasty and a stent. What is a disadvantage of endovascular procedure? Glaring, which none of us can miss. You really don't know whether there is a dead bowel inside or not. Okay, CT is not totally dependable as to the viability of the bowel. So if you have absolutely no abdominal signs and the CT shows a small segment that is hypoattenuated, and you can do these procedures and demonstrate that hypoattenuated segment has reperfused, then you may want to wait. But that is a very, very small number. The big problem is that even after you do the endovascular intervention, you may end up with a bit of dead bowel, may go on to sepsis, which may become irreversible. So if there is something that can be salvaged, endovascular procedure is not the most preferred or is not the favored intervention. Some people have enthusiasts have done it and done it a lot, but it doesn't really work. So open surgery is the answer, not even laparoscopy. Where would you consider laparoscopy in preference to open surgery? Sanya.
So if we are in doubt and to have a look,
Okay.
or if it is a very small segment of bowel that is involved, which can be resected laparoscopically.
Okay, good. That's what it is. If you're already nihilistic, you know that there is a large bit of bowel that's dead probably, and you want to prove it to everybody, then do a laparoscopy and come out. Instead of doing a laparotomy and coming out, do a laparoscopy and come out. Or you have a small segment that is involved, or a small segment differential, as I mentioned, segmental enteritis, for example. Now, I've done at least 4 or 5 cases of segmental enteritis. Laparoscopy assisted resection I've had to do, where, it's not a mesenteric thrombosis, but a segmental enteritis. If there is still a doubt about your diagnosis, you can put a laparoscope. But by and large, if it is a classical mesenteric thrombosis with partial necrosis of the bowel, not the whole bowel, then the procedure of choice is still open surgery, where you can do a thrombectomy, usually retrograde. You can't go to the origin of the SMA. So you go distally where you can loop it and open it, and then do a transverse cut and take out the embolus from the distal part to the proximal part. You can do an embolectomy. You can do an endarterectomy, do a bypass. Where would you put the bypass to? Any idea? Nikita, have you read about what is the preferred conduit and where would you put that bypass? This is all you need to know. You're not going to do it, and none of us is going to do it actually. But as surgeons, you must know. What is the preferred conduit?
Not sure, sir.
Yes. If there is a bit of dead bowel, what is your problem? We've been talking about high lactate, high CRP, hypotension. What is the problem? What is your concern? We talked about gas in the portal vein. What is your concern there? So many hints I've given you. Samir mentioned about giving broad spectrum antibiotics. Why are you giving broad spectrum antibiotics?
Prevention of translocation of bacteria.
Not translocation. You are worried about sepsis all the time. So would you use a prosthetic graft in the presence of sepsis?
No, sir.
No. As simple. Work it out. You guys don't have to mug it. It's very all common sense. Surgery is all common sense. So you would only use a biological graft. What is a good biological graft for you?
Reverse saphenous vein.
Saphenous vein. That's all. Okay? Very simple. Harvest the saphenous vein from the same patient, and you can put it. Where would you put it? In an SMA thrombosis at the origin. You can either put it to the aorta. Usually they use a proximal aorta, even proximal to the celiac artery, where the celiac artery takes off, so that there's no kinking. The concern is kinking. If you put it right closer to the origin of the SMA, then you have a problem with kinking. So you put it right, try to put it proximal to the origin of the celiac artery, or you can put it to the iliac artery. Again, a longish segment. From there, it goes to the SMA just beyond where the blockage is. So that is the bypass that people use. And of course, bowel resection, very important. So I've said in laparoscopic, really the only role is diagnostic. So that I think I have a picture of one of my cases. Yeah, okay, it'll come a little later. So the preferred approach, as I said, is surgical, much more than endovascular. I won't go into these, but almost certainly you'll end up with a short bowel syndrome. Any surgeon doing resections for ischemia must have in mind that he should try and avoid short bowel syndrome. We'll have another class on short bowel syndrome and its consequences later. This is what I said about expense, because if you end up with short bowel syndrome, to keep them alive, you have to use TPN for a very long time until the bowel recovers, months together, and that's almost impossible in our country, and it's very expensive. And always, you will never be sure whether you have left any ischemic bowel back or not. You will never know. All the classical things that we know about is, about the perfusion. We talk about peristalsis, bleeding from the edge, and ICG and things like that. Whatever you use, it's impossible to be sure whether you have really taken out all the bowel that is necrosed. Because remember, in an attempt to reduce the possibility of short bowel, we try to leave as much bowel behind as possible. And within 24 hours, it may become necrotic again and give rise to sepsis. So laparostomy and second look in 24 hours is almost a must in all resections for ischemic bowel. Okay, this is the kind, this is a very old picture of mine. This will not happen now, because I've done a laparotomy. I've seen that the whole bowel is dead. I'll put everything back, close the abdomen, and tell the family, I'm sorry, I can't do anything. This really should not happen today, because I would today have done a laparoscopy to come to the same conclusion. Here, this is the point I was making about whether something is viable or not. You can see that this is obviously dead. I suppose you can see my pointer. This is obviously dead. What about this? It's injected. What happens to this in the next 24 hours? We will never know, but I would not resect it. So I would leave it behind. Anastomose if you want, or you can exteriorize it and do a laparostomy and go in 24 hours later. to see what's happening. Okay. And so this is one of the intestinal stroke units, which has given a kind of algorithm, and there is really nothing much. This just summarizes what I have said so far. High clinical suspicion is important. If there is peritonitis, please go ahead and do a laparotomy. Okay, no peritonitis, get a biphasic CT angiogram. You can see the disruption arterial flow, bubble wall thickening, all the things that were mentioned. You can also look at splenomegaly ascites and portal and venous gas. Again, gives you indications for venous thrombosis as well. We looked at all the medical management. I'm not going to repeat that here. And then if it is an arterial embolus, which you see here, open surgery, do an embolectomy, angioplasty. It could be retrograde or antegrade. And they have not mentioned bowel resection here, which you have to if there is anything that is necrotic. And in endovascular, do an aspiration and a thrombolysis. For venous, very rare that you do any venous, thrombectomy or embolectomy and things like that. You use continuous IV heparin, but of course, you look at the viability of the bowel, even in venous disease, and do a resection if it is necrotic. Non-occlusive, correct the underlying cause. Please note that the outcome from NOMI is really very, very poor. Okay, this is about acute mesenteric ischemia. Okay, Ramakrishna, anything to add or questions or doubts?
No, nothing, sir. Very well, very comprehensive, and many
Ravi?
things we came to know.
No, sir, I think everything is covered. It's just that I think, as you said, the prognosis has remained poor, for a long time. And only thing I don't even, but mesenteric bowel transplant has come in, and
Yes.
that might change the picture a little.
Yeah.
And endovascular, if done early, may salvage some of the cases, which may be the two, sort of beacon lights in the very dark picture of mesenteric ischemia.
Correct. Correct. All right. So I think we have not mentioned about chronic mesenteric ischemia. If you guys have read up about it, okay, let me ask Vikita, tell me something about chronic mesenteric ischemia and how it differs from an acute mesenteric ischemia. You guys can read up about it in detail, but there are a few, salient features where a chronic ischemia differs from acute ischemia. We must start with clinical symptoms, investigations, what you would find different in that. In clinical symptoms, what you would find different is any change in the intervention. Okay, these are the three main things that you have to cover. In the symptoms, would you find anything different?
Yes, sir. So basically, chronic mesenteric ischemia is a manifestation of peripheral vascular disease. So patient will also be having the coronary artery and peripheral vascular disease symptoms.
Okay.
Along with that, specific thing regarding the abdominal pain is it's postprandial pain, sir.
Correct.
Which usually starts after half an hour of intake and lasts up to 3 to 4 hours, sir.
Okay.
This is the pathognomonic of chronic mesenteric ischemia.
Correct. So what are its consequences? What happens after that to the patient? There's a classic food fear. Okay, the guy cannot eat because when he eats, he gets pain. So what happens?
So
weight loss.
Weight loss will be there, sir.
Yeah. So the classic features are postprandial pain, food fear, and weight loss. Yeah. All right. So you mentioned about atherosclerotic disease. Is there anything else that can cause chronic ischemia? The rarer things that we talk about, median arcuate syndrome, for example, has a larger proportion in chronic ischemia than acute ischemia. Okay. So, Samir, what is this median arcuate syndrome, man? What is the median arcuate ligament? Aynash?
Compression of the celiac artery because of like median
What
arcuate
artery?
ligament.
What artery?
Celiac artery, sir.
Very good. By the median arcuate ligament, which is a ligament between the two sides of the diaphragm,
Diaphragm.
which arches over the aorta. Okay, that good. Yeah, that is a median arcuate ligament. That can, the incidence of such rarer things which you don't normally think of in acute mesenteric ischemia, you have to think of it in chronic mesenteric ischemia. That's as far as symptoms are concerned. Okay, and because it is a chronic thing, this business of bowel necrosis is less likely, because if there is an acute on chronic process, it comes under the acute mesenteric ischemia. Here, necrosis is not very common. So endovascular procedures can be done more commonly and more efficiently. Stenting and balloon dilatation of the stenotic segment can be done. And as you rightly mentioned, it is systemic disease. So these people will have a higher incidence of PVD, CAD, and cerebrovascular disease, CVD. So it's a spectrum where this can also occur. But as I mentioned, the endovascular procedures have a major role to play because necrosis is not a major feature in this. Prognosis is still limited, even after stenting, even after all these interventions. The basic disease continues, and well over half of them will have continued problems. Okay, that is all the major differences that you need to think about. Ramakrishna, you want to add anything to that?
Nothing, sir. Yeah, investigation wise, sir, same CT scan or angiogram.
Same set of things. CT angiogram is the investigation of choice. Yeah.
Yes.
Okay. Questions and doubts from the students, followed by closing comments by Ravi.
Sir, one finding, like when we had COVID-19, there were a lot of mesenteric ischemia.
Absolutely.
And even in the phase post-COVID also, there were a lot of cases of mesenteric ischemia.
Absolutely.
So is there any, what is the pathophysiology or anything, sir?
There is COVID is a hypercoagulable state. If you see the algorithm that I put up there, COVID-19 was one of the, can you see here? Atrial
Yes.
fibrillation, sepsis, COVID-19, and hypertension. These are the risk factors. So basically, COVID is COVID induces thrombophilia, thrombotic episodes everywhere, MI, PVD, vascular disease, bowel, everywhere it was important. And that's why you have this. But now I think we have got over COVID. I don't think the long COVID also does not lead to this degree of thrombophilia. So that's why I didn't stress on it now, being so many years away from COVID. But if somebody does get COVID, please think of it as a severe thrombophilic condition.
Okay.
Sir, even this COVID vaccines, are there any evidence?
Yeah, you're looking into it. I haven't seen much evidence for that, Ramakrishna, really. There have been some isolated reports, but while there is clear evidence for COVID disease itself, vaccines, to my knowledge, is not very risky, but we really have to look at the literature in depth. Yeah. Okay, so closing comments from Ravi.
Excellent class, sir, but still very depressing scenario. I think high index of suspicion, early diagnosis, early intervention, and counseling of the patients and relatives about the prognosis. Hopefully, there will be some newer modalities which may help to improve the I don't think there will be dramatic improvement because of the nature of the condition. And fortunately, it is rare. I think that is the main thing. And as the sir said, the second look relaparotomy is very extremely important. And try and conserve the bowel as much as possible with the hope that the adaptation happens over a period of time, especially in people who can afford the longish treatment. I think it is much more, there are a lot of home parental nutrition patients in the UK and US where I think the insurance covers it, but I think it may not cover. I don't know whether it will cover it here, but I think it is still a very disease with extreme, degree of morbidity and mortality.
Right.
Well initiated. Thank you, sir.
Okay, Nitya and Sanya, I don't know if we have discussed short bowel syndrome, but kindly put it up. It's an extremely important topic, and anybody doing any bowel surgery must know practically everything about short bowel syndrome. Okay?
Yes, sir.
Please
Yes,
use
sir.
that as a class. Yeah. Thank
Yeah,
you very
sure.
much, friends. Good night. I'll close the meeting. Thank you.
Thank you, sir.
Good night, sir.
Thank you, sir.